Flow of speech. Some patients with mania or schizophrenia may demonstrate pressure of speech. A few patients with schizophrenia, whereas, may never speak above a whisper or speak with an unusual strangled voice, which is known as work stimming. The quality of speech in catatonia, as in motor aphasia, may be strange and stilted, as if the patient is unaware of the language. Now, next is verbal stereotypies. These are words or phrases that are repeated. They may be produced spontaneously or be set off by a question. In verbigeration, one or several sentences or strings or fragmented words, they are repeated continuously. Schizophasia, it refers to speech confusion. There is gross thought disorder, but the patient speaks in a normal way. Now, disorders of posture. Abnormal postures, they can be seen in individuals in context of attention-seeking behavior, nervous habits in troubled adolescents, or over-anxious personality. Now, there are two types of postures defined here, manneristic and stereotypic. Manneristic posture is an odd posture that is an exaggeration of a normal posture and it is not rigidly preserved. Whereas a stereotypic posture is abnormal and non-adaptive posture that is rigidly maintained. For example, as seen in this picture, here it is a picture of a catatonic patient maintaining a rigid posture, and the second picture is of a patient. This is known as psychogenic pillow, in which the patient usually rests their head above the pillow, and this may have they may continue to do so for an hour. The perseveration of posture. The patient tends to maintain for long periods postures that have arisen by chance or which may have been imposed by examiner. The patient allows the examiner to put their body in strange postures and then maintains them for at least 1 minute and ends with the body slowly sinking back into the resting position. Now, waxy flexibility. It is in this, the examiner, when he puts the patient into some posture, there's a feeling which resembles the bending of a soft wax rod when the passive movement stops and the final posture is preserved. Catalepsy. In catalepsy, there is no resistance to passive movements, but as soon as the examiner releases the body, the muscles get fixed in the abnormal posture. Now, the prerequisite here is that the patient should always be told first that they are not obliged to leave their body in that position, which is put by the examiner. Otherwise, the patient may feel that maintaining the posture is a part of the test. So one approach is taken in which we take the arm of the patient by the wrist and try to take their pulse. So when the arm is released, normally the patient will put down their hand. But in a patient, for example, with catatonia, it does not return to its resting position. Next is abnormal complex patterns of behavior. So in abnormal complex patterns of behavior, there are goal-directed and non-goal-directed behaviors. In non-goal-directed behaviors, first is stupor. So stupor is a state in which there is complete loss of activity and there is no reaction to external stimuli. It can be regarded as an extreme form of hypokinesia. There is psychomotor inhibition and obstruction. The patient may produce a general slowing down of activity, and when it gets severe, the patient may approach stupor. Completely stuporous patients are mute, but in substuporous states, patients may reply briefly to questions. It is seen in shock, dissociative disorders, depression, psychosis, catatonia, and organic brain disease. Now, psychogenic stupor. In this, there is severe psychological shock. For example, a bombardment during wartime, and the patient may be paralyzed with fear, unable to retreat from danger. In space-occupying lesions affecting the third ventricle, thalamus, and the midbrain, they may produce a stuporous state in which the eyes are open and the patient appears to be alert. The patient reacts slightly to stimuli. There is lowering of levels of consciousness and failure to register new memories. This is known as akinetic mutism. In epilepsy, when there is continuous epileptic discharge on the EEG or repeated bursts of such discharge may occur, which is known as petit mal status, stupor may occur. So the possibility of a neurological disorder should not be overlooked in a rapidly developing stupor. So an EEG, CT or MRI of the brain or even a lumbar puncture may be required to establish a diagnosis and rule out any organic pathology. Now the opposite of stupor is excitement. Here there is extreme hyperactivity, constantly motor unrest, which is apparently unpurposeful. Psychogenic excitements may be acute reactions or goal-directed reactions. These are commonly seen in mania and catatonic schizophrenia. In mania, the patient is irritable and cheerful with flight of ideas, whereas in catatonic excitement, there may be violence, which is senseless and purposeless. Now, in delirium, there may be ill-directed overactivity. So many delirious patients, they are frightened. And when approached by a healthcare professional, they feel that the healthcare professional is going to attack them. Whereas in pathological drunkenness, it is a form of organic excitement. Here, there is an excitement which is senseless violence after the patient has drunk a small quantity of alcohol. So, for example, a husband, after drinking 2 or 3 beers, may murder his wife. And the next day, when he wakes up, he finds his wife laying down on the ground dead. And he is also covered in blood. His wife is also covered in blood, and he has no memory of whatever happened. So, this is known as pathological drunkenness. Now, goal-directed abnormal patterns of behavior, they occur nearly in all individuals, and there may be aggressive behavior or there may be suicidal or self-injurious behavior, for example, in patients of depression, who first may kill their family members and then they may commit suicide, or there may be extended suicide also because the patient feels that their children, they are insane and their children may also get the insanity, so they kill their children as well. There may be disinhibited behavior in mania or in hebephrenic schizophrenia, wherein the patient is joking around and there are silly smiles. Now, last one is movement disorders, which are associated with antipsychotic medications. So there are the movement disorders associated with antipsychotic medications are basically extrapyramidal symptoms, which include dystonia, pseudo-Parkinsonism, akathisia, and tardive dyskinesia. Now, dystonia is uncontrolled muscle spasm in the body. For example, eyes may roll upwards, which is known as oculogyric spasm. Head and the neck may get twisted to the side, which is known as torticollis. The patient may be unable to swallow or speak clearly. Now, in pseudo-Parkinsonism, there is slowness of all the movements and there is bradyphrenia. There is slow thinking. There may be tremors or rigidity. In akathisia, it refers to restlessness, a subjective, unpleasant state of inner restlessness with a desire or compulsion to move. For example, a patient may have a foot stamping when seated, or constantly crossing and crossing the legs, rocking from foot to foot, or constantly pacing up and down. In tardive dyskinesia are abnormal involuntary movements. For example, lip smacking or chewing, or tongue protrusion, coriform or hand movements, dystonic and choreoathetoid movements of the lips. So these 4 are the abnormal movements. My references are Fish Clinical Psychopathology and Maudsley Prescribing Guide, Psychiatry. Thank you. Schizophrenia is speech confusion. So it is basically here the patient has a disorder of the thought. The patient may speak normally in a normal tone, but he is confused.
Can you describe it? Is it schizophrenia?
So he said it is speech confusion. There is confused speech on the part of the patient.
Sounds like a physio, but not physio. Tell the difference between grasp reflex, post grasp, and automatic obedience.
Automatic obedience of?
Like you tell the patient not to do something till he is given a command. So the way you say that grasp reflex comes across like automatic obedience.
Yes.
So is it different or is it similar?
Sir, in automatic obedience, regardless of what the consequence is, even the consequence, if the consequence is pain, the patient will still do it. That is automatic obedience. And so grasp reflexes, so a patient may not follow the instructions, whatever is told to him.
It's not grasp reflex, it's
It's
post
post grasp, sorry.
post grasp. What is grasp reflex?
So grasp reflex basically, sir, it is to find out any frontal lobe region. Sir, in this, a patient grabs all the objects which are given to him. For example, we may
You see grasp reflex commonly in normal scenarios. You see grasp reflex anywhere.
so grasp reflex is seen in some treated OPD patients who are having defective dementia. So normally, so children,
So it is lost. You see, say the primitive reflexes they are
yes,
usually say when there is some CNS pathology. Reflexes are lost. They get mental reflex.
yes.
So how do you do grasp reflex?
So in grasp reflex, we take patient's hand and we run our fingers on the patient's palms. So if the patient's grasps our hand very much, so if it is unilateral, it indicates frontal lobe region. And if it's something bilateral, lateral, it may indicate disorders of the cortex.
What is question? So I will ask you, how will you test automatic obedience? One direction you is बोलते हैं कि आप जीप निकालोगे तो पंच मारोगे। आप चाहे तो जीप निकाले या ना निकाले। अगर आप उसको बोलोगे जीप नहीं निकाले तो नहीं निकालेगा। आप अपना पिंच मारोगे तो जीप नहीं निकाले वो भी ऑपरेशन हो गई। तो ये बोलना है कि आप मर्जी है आप चाहे जीप निकाले या ना ठीक है फिर आप डायरेक्शन आप जीप निकालोगे तो मैं पिंच मारूंगा फिर आप चाहे जीप निकाले या ना निकाले patient like even patients who are normal first try doing it then you will see that patients are submissive they do follow but there will be some irritation okay some hesitancy will be there but in California patients will do okay.
Ma'am, mannerisms are both are repetitive movements, but mannerisms are goal directed. They may even be found in normal individuals. For example, patients who want, for example, individuals who want to seek attention. So they may have particular behaviors to grab attention, but stereotypically are not goal directed. For example, a patient may, and stereotypically they can be of recurrent utterance. The patient may keep on speaking words or phrases again and again. Perseveration. Perseveration is beyond the point of relevance when a patient keeps on speaking and speaking. But stereotypically also. Or because no, ma'am. This can be no, ma'am. They can be normal mannerisms, normal anxiety also.
Perseveration is more than speech. Stereotypy motor. Perseveration. Speech of motor. Motor should be perseveration. Example. Perseveration का क्या क्या
Switching the patient with dementia, the patient keeps on doing the same activity again. No task.
Persistent of that when it is not relevant. Stereotypy is like it is not affect. It's just in this. Perseveration starts off with one thing, then it keeps on. I mean,
Yes, ma'am. Not stereotypy. As in, for example, the example which is given in fish is the examiner, a patient kept on repeating words or phrases again and again for an hour. For example, I met me,
according to
which made no sense.